Before we get into today's episode, I want to take a moment to tell you why I've made clinician retention the focus of my work and where the show is going. I've spent years inside healthcare systems. I've seen what happens when the structure isn't set up to allow clinicians to do their best work. I've watched talented clinicians leave organizations that could have kept them. Not because the problems were insurmountable, but because no one had diagnosed them clearly enough to fix them. Here's what I know. The drivers of clinician turnover are identifiable. They're fixable, and the organizations that solve them aren't doing anything magical. They've just finally started looking in the right places. That's what this show is about. Every episode is built around the structural conditions that cause clinicians to leave, what works, what doesn't, and what executives can actually do about it. If you lead a health system, a medical group, or a clinical division, and you're tired of watching good clinicians walk out the door and go down the street to your competitors, you're exactly who I'm talking to. Now let's get to it. I'm Dr. Laura Suttin, and this is Designing Healthcare That Cares, a podcast for health system executives who are ready to stop treating turnover like a symptom and start fixing the structure behind it. Let's dive in. Welcome to the Designing Healthcare That Cares podcast. I'm really excited to have our guest today. Dr. Terry Adirim is a board-certified emergency physician and physician executive with more than 30 years experience spanning academic medicine, federal health leadership, and health policy, with a sharp focus on AI in healthcare and what the changes in our healthcare system actually means for patients. She's the author of The Prepared Patient, Your Guide to Surviving the Healthcare System from Johns Hopkins University Press, and editor and lead author, Digital Health, AI, and Generative AI in Healthcare. She's currently a chief medical officer and advisor to healthcare startup companies. She's an author. We'll definitely be talking about her book, and an expert consultant on health system transformation. She's written more than 100 peer-reviewed papers and given over 100 national keynotes, and she translates all of it into plain, practical advice you can use the next time you're staring at a hospital bill or a denied claim. Dr. Adirim, so good to have you on.
Yeah, it's great to be here. Thank you, Dr. Sutton, for inviting me.
Yeah. Tell us a little bit about your journey into AI, into healthcare transformation. How did you get to where you are now?
Yeah, that's a great question. And it was a long journey and zigzagging, going from one kind of thing to another. When I first went into medicine, I thought I was going in one path. I started in academic medicine, really enjoyed that, clinical care and research and program building. But then I had opportunities along the way, which kind of take you in another direction. And as a mid-career, I became a senior health official in the federal government. Thought I would only do that for about a year, but really enjoyed that, having an impact on people from a national standpoint as opposed to one-on-one, though I was still practicing medicine. I was doing both. And I found practicing medicine on the front lines was really helpful in doing the federal government work and the policy making. I then pivoted and really wanted to be in a leadership role in health systems. And so did that. And I was greatly fortunate to be in a position with the Department of Defense, with the military health system. A lot of people may not know that that department runs its own healthcare system with hospitals, clinics, and a health plan. And I was in a role with a really long name, but essentially the chief medical officer for the system. It's a great position. I got to do all the things that a chief medical officer would do in any healthcare system. And then I wanted to go back out into academic medicine, did that for a year, but then when I started, the pandemic hit. And so that kind of took me on a different trajectory. And I had the good fortune to be offered a position within the Biden administration back at the Department of Defense, where I got to lead from the top health position there during the COVID pandemic. And then they asked me to go over the Department of Veterans Affairs to lead their EHR modernization effort. I had done a little bit of that as the chief medical officer over at the Department of Defense. So they wanted me to come over to the Department of Veterans Affairs and learn so much about digital health, electronic health records, and so on. And when I finished there, I said, you know what? I have a lot that I would like to share with what I've learned. And that's where I both edited and wrote a textbook on digital health and AI and wrote this book that's coming out this summer. So that's been the trajectory of my career. And oftentimes you just don't know when opportunities come up where those opportunities are going to take you. And certainly the pandemic, I think, had a big impact on most of us in healthcare. It's changed a lot. And, there were a lot of people thinking that maybe there were a better way of doing things. There was what people were calling burnout, moral injury. It was really, really a tough time for people. And I think what greatly accelerated after the pandemic were new healthcare startups looking at different models of care. And I wanted to be a part of that. So I advised several healthcare startups, which is very exciting to be a part of an organization doing innovative work and going from the beginning to taking it to scale. So I've been very fortunate in my career.
Yeah, that's an incredibly impressive background. Thanks for sharing all that. And thank you for all your leadership and everything that you've done and multiple roles within government and within practice. I definitely share that sentiment about how the pandemic changed things. And I know everybody sees it a little bit of a different side of it and has a different perspective. I was working for a large health system at the time that we were really just beginning to start to use telemedicine. And as soon as that public health emergency became in effect, of course, our telehealth capabilities exploded because they had to. I think we had just gone live on this particular platform over the week prior. I mean, and that was just coincidental. So we had to scale that up very quickly, make sure that not only did we have the capability to do it, but the patients did. And I think it really highlighted for us, it dispelled a lot of myths because a lot of our patients were senior citizens in primarily Medicare Advantage space. And so there were some myths around, well, the patients aren't going to be able to, they don't have the technology to do this, or they don't want to do this. Well, we were very wrong about that. And we were proved wrong about that.
And I feel you on this because I was down in South Florida at a medical school as a senior associate dean for clinical affairs. And I oversaw the faculty practice with, just like you in your experience, at least 50% of the patients were, senior citizen. And when that pandemic hit and we had to shut down in-person care, it was exactly what you had. Within 24 hours, we had to have policies, we had to have a platform, we had to be able to do it. And I'm like, oh my God, I hope we're able to still see patients. And wouldn't you know it, we didn't lose. The people wanted to use that virtual health platform. And what I thought was interesting was that when I was in the military health system, even back in 2018, as a policy person, I kept pushing, we need to do virtual health. And healthcare, I'll be the first one to admit, we're Luddites. We are resistant to change. It's like, where did you move my cheese and all of that? For all good reasons, some good, some not right good reasons. And it was hard to push that. But even the military health system had to, boom, do virtual health. So I had the same experience as you. It's kind of funny that you're saying it exactly how I would say it too.
Yeah, that is interesting. I would agree. We were a little bit Luddites too. We were a little bit slow to adopt things like patient portals and apps and that kind of thing, which I can't think of a practice nowadays either that I've been to as a patient or a family member where there's not some electronic mechanism to contact the office, whether that's through an app or a patient portal or some feature like that, let alone AI, which I definitely want to get into.
What's interesting is that we assume that patients wouldn't want to do it. But then if you think about it, older people or people who don't like electronic things in their healthcare were using ATMs. They were using all kinds of other electronic things for other parts of their life. So why not health?
Right. Yeah. So. And today's over 65 population is pretty internet savvy. I mean, they're almost as used to it as my kids, and so they all typically have iPhones and they know how to work their way around it. So yeah. And they also want to have the access to care. And from the physician standpoint too, we were happy to do it. It was almost like a little bit of a break in the day to have a virtual visit in the middle of the morning or middle of the afternoon. And you get to sometimes physically see a side of the patient that you don't normally see. You see them in their home environment Where do they spend most of their time? Are they sitting on their couch? What does their home situation look like? Do they have family there that can be there with them during the visit? So it was interesting that the pandemic forced that for us, but I'm glad that we were set up such that we could scale it at the way that we did.
And it was interesting too, because my pediatric colleagues, I'm a pediatric emergency physician. So we were doing learning collaboratives and other things amongst ourselves. And the information that they could glean from, somebody being at home, speaking to a mom or dad and the kids in the background, they could really gather information they wouldn't get in the office. So I'm just underscoring your point that it was a different perspective. So.
Yeah, definitely. I was working with a lot of older folks and you're working with a lot of younger folks. And so you also need to see what that environment looks like. So yeah. Well, so I want to talk about AI, and I know that's, you've done so much work around this. And so I want to learn from you as much as anything. And I think when we talk about AI in healthcare, and there's so much conversation about it, so again, my perspective as a patient and then taking family members to visits, the clinician that opens a visit and says, I'm going to use an AI app on my phone to record the visit. And I've seen these work really well. The part-time practice that I do is an urgent care type of setting. And so we don't use that because our visits are pretty focused. But I've looked at visits of my family members, myself, of clinicians that have used these, and they look great. I'm reading it. I'm like, that's what happened during the visit. And then when I coach with and consult with healthcare organizations, I'm starting to hear more and more positive things about the AI scribes, essentially. And so
Right.
I think there was a little bit of a learning curve at first, just like any AI tool has to work for you. You have to train it. And then I think about AI from the administrative kind of back end, like how do we use AI for healthcare claims? And that's being talked about a lot in the conversations lately with our payers. How do we use AI to make better diagnoses in pathology? How do we in radiology? Those types of things. And then I think about it more from the clinician workflow standpoint. So not necessarily the scribe, but how can I pull on-demand information on my patients? How can I look up clinical information on a patient? I'm not sure what these constellation of symptoms mean. So I think about AI in really those three buckets. It's like the point of care, patient, clinician conversation, scribing. Then there's the clinician workflow standpoint or back office workflow, and then more the administrative support, how healthcare is delivered.
And that's a really great way to bucketize, how AI is impacting healthcare today. And as you described ambient AI scribes, I could only think about the reason why it's having success is because it really solves problems for the physician or the clinician, any clinician. And, I've been around since we had to write into medical records and go to the medical records department and get the big stacks of records. And then electronic health records were supposed to stop that from happening. We could, don't have to worry about handwriting anymore. Whereas it was supposed to address a problem, the electronic health records, it was not designed with the clinician in mind. So it created more problems. It was like you're just a typist and you weren't interacting with the patient anymore. And that was a really tough thing. I mean, people still complain about the electronic health records. And the reason why ambient AI scribes from the point of view of the physician is meeting success, even though there are change management issues with having to learn how to insert it in your workflow and change a little bit of how you do your work, is that it solves that problem of staring at the keyboard and not at your patient. And, me working in the emergency department, I glean a ton of information from walking in the room and talking to the patient and seeing how they're sitting, what their face looks like, how they're interacting with others in the room. I gather a lot of information, but if your face is in the keyboard, you don't get that. A lot of the information that you get is not necessarily organized. So ambient AI scribes also do something else, is that it organizes your encounter into a note, right? So those are things that you're solving for the clinician. And so that kind of tool is going to be successful. The other things that you described, I think, are very exciting too, is that clinical decision support bucket, right? open evidence has really skyrocketed. I'm sorry, I'm mentioning the name of something, but 2/3 of physicians use that because it's really good, right? You get not only answer to your questions, but you get the studies, you get the guidance, and it's all in one site, and think how powerful that is if it's integrated right into your electronic health record. So while you're using it, you just click a button and you can get that clinical decision support. But where I think it's going to have value for the entire healthcare system from the point of view of health systems, institutions, and clinicians is that digital front door plus that back office type work. Our administrative costs are huge in this country, unnecessarily. And it has to do with the complexity of our healthcare system, right? I mean, we just kind of layer upon layer upon layer of processes that you have to do, between coding, prior authorizations, other authorizations, reviews, and all kinds of other things that you have to do in order to be in the healthcare business can be done a lot quicker if you use AI-powered tools. You really articulated it very well what the buckets are. I would just add the digital front door, right? I joke around with people because I've seen different tools where you can do your appointments. If there's like a multi-state practice or a big, large healthcare system, being able to go into that one system that's an AI-powered appointment system that kind of gets you to where you need to go automatically, that's great. I joke around. I don't want to talk to a person. If you want an agentic agent to help me get my appointment, let's do that. I do that to make my haircut appointment, right? Why can't I do that for healthcare? I don't want to talk to a human. Think about it. The number of people who are doing administration in healthcare has skyrocketed over the years, and that adds costs. Not that I want anyone to lose their jobs. I mean, I think people could be doing other things, but it really adds a burden to the healthcare system and to everybody, whether you're a payer, whether you're a healthcare system, any piece of that. So you've really identified the promise of AI. Now, there's some cautions, and I'm sure we'll get to that.
Yeah, thank you for all that. And you mentioned open evidence. Yeah, we're not affiliated with them at all. And so it happens to be a great tool. And so I agree, it's a fantastic tool. Yeah, I love the kind of the digital front door piece. And again, we think about what are some of the barriers that our patients are feeling. There's one particular practice that I have gone to and still do occasionally that I used to be, I would call and maybe I'd be on hold to make an appointment. Now I call, and even just to get through the voicemail setting, I have to enter about 6 different pieces of information about myself. Then I get the voicemail setting, and then I'm told, leave a message and we will call you back. All they have is a voicemail system. Leave a message and we'll call you back in the order that your message was received. And it's so frustrating. And I think, well, I really just want an appointment, or I missed a phone call from one of their clinical staff that's calling me and I need to call them back. And I got so frustrated one time. The office is close to my house. I just went and showed up and I said, I can't get through on the phone to you.
I don't blame you. There are companies that handle that, right? I mean, I think for all of these things that are patient facing, as long as you have escalation policies, like ways where you can get to a human if you need it. I'm a type of person, if I get frustrated, I'm like, I don't want to deal with the system. I was getting frustrated listening to you describe it. And I think as long as there's either a human in the loop or a physician in the loop, I think these systems are great because for the 80% of people that could go through it a lot quicker, in 2 minutes, as opposed to what sounded to me like your 20-minute ordeal on the phone, I think that's a lot better. I think that reduces friction for the patient. It reduces burden on the practice. And there are companies that are doing that work, that have products, AI-powered tools that are doing that. I think that's a great way to use AI.
Yeah. Again, it's a no-brainer for me to think about bringing something like that onto my practice. And I want to go back to something that you said, though, because it sparked something for me. So you said something that I think a lot of people don't realize that EHRs were not built for clinicians. They were built for billing. And the clinicians that I work with that struggle with EMRs and getting their notes on time and all of these things that we've struggled with for decades don't really realize that in their frustration. And so I'll share that as a validation. And they're surprised to hear about that, as our patient that I talk to. And so I don't think that's widely known. And so when we think about the other thing that you said about just the complexity and the layers of administrative work, I think I do have a fear that as we look at it, so take ambient AI scribes or even a clinical decision support, that we would be layering on top of EHRs, layering on top of current portals or whatever clinicians are using, data lakes, all these different systems that we're using to
Mhm.
gather information. Am I alone in that worry, or is that something that we
No,
need to watch out for so that we're not
no,
just layering?
no, absolutely. And I talk about this with other clinicians and people who do tech, is that we don't want to have the same phenomenon where EHRs come in and everybody hates them. You have to use it, but you don't want to use it. It's frustrating and people do workarounds and all of that. I don't think that's necessarily going to happen. I mean, burned once, you don't want to be burned twice. I think the best systems and the AI tools that are going to be the most successful are the ones that integrate into the electronic health record and also integrate into the clinician workflow. And I think as that has a really good user experience and interface, and that it's easy to use and intuitive, that it's designed in that way. Because EHRs were not designed with the end user in mind. That's, end of story. But I think there's more attention and new technology to that. And I think what's going to eventually happen is we as end users are not going to even realize that we have this EHR because these tools are going to be built on top of it. You're going to be interacting with these AI tools and doing whatever you need to do. And you may never even have to go into the EHR. It will be necessary because it is that, record for the patient and it's how the traffic flows, the data flow. Like you mentioned a data lake. Well, it's how the data comes in and comes out. But I'm hopeful that it's going to be better now that we're in this time. I think we're in a period of transition. I mean, I don't think anybody can 100% predict exactly how things are going to go because we're in this period of some places are doing pilots, some places have really adopted. But I have hope that it's going to improve our quality of work life. And it's going to improve things for patients, right? Hopefully it'll reduce friction. Now, is it going to fix our healthcare system? Some people say so. There's a couple things people say, even to this day, that AI is going to replace clinicians, replace physicians. I 100% don't believe it. I think we're always going to need physicians. But I think it's going to make things better for both the physician and for the patient.
Yeah. Yeah. Thank you for that. I absolutely agree with you that AI is not going to replace clinicians. There's always going to be a need for the human. And just like you described the scenario of walking into an exam room, and especially if it's a patient that you can tell immediately how sick they are and the things that you can't get from text or speech or whatever is being fed into the AI.
It's context. AI, at least not now. It doesn't have that context, doesn't have that continuity. I think it's going to be an amplifier. I think it's going to reduce friction. I think it's going to make things better. It will not fix our healthcare system. I don't think it's going to be the answer to not having enough subspecialists or enough primary care. I don't think it is the solution for rural health, though it will be a solution. I mean, just like virtual health, and you probably know this, virtual health was supposed to be this panacea for rural health. Well, I think it's going to help, and it has helped, but it's not the solution, right? I mean, if you're a pregnant woman in the middle of nowhere and, you need a place to deliver and it's 2 hours away, virtual, you can't do that virtually. I mean, I don't think it is the absolute ultimate solution, but I think it's going to help with some of those friction points.
Yeah, absolutely. Not that I want to necessarily shift toward the negative, but you mentioned some cautions with AI. And so I'm curious, what does that look like for you?
Sure. I think for those of us who are users, I still harken back, and I'm not old fashioned. I am one of those at the tip of the spear. I love tech stuff. When EHRs came in, I was like one of the first people to really know how to use them, did my order sets, did all kinds of stuff. But there was just something about writing the patient note, actually physically, with the pen in hand and writing it, that imprinted in my memory what was going on with the patient. When I would finish a shift and I had seen 30 patients in a shift, I could remember every single patient and I could do the notes right afterward. I could, I need to fill in review of systems or what have you. With EHRs, when I would have to finish the notes after the shift, I could barely remember, because I didn't have that imprint. So that's the downside of EHRs. It will probably be the same for ambient AI scribes. There'll be a little bit of that missing, that ability to print on your memory. I think too, people talk about clinical decision support, losing a little bit of that memory and analytic ability. I do think, and even when I was going through medical school, I thought it was ridiculous that we had to memorize all of that stuff. Like, why are we cramming all of that information? Now we have systems where we don't have to memorize that. You have the OpenAIs and other tools to do that. It's sort of what reminds me when my son was in third grade, he wouldn't learn his timetables. I mean, like, he was advanced in math, but he refused to learn his timetables. And I said to him, why will you not do this? And he said, because that's what calculators are for. But I was glad I learned my timetables because I needed it in pediatrics, right? I can automatically do it in my head. So there's a reason for something. So I think we're going to need to sort out from a medical education standpoint and a practice standpoint, what it is that we really need to learn and know versus what we concede to a clinical decision support tool. We're not there yet. We haven't done that kind of work. So there could be, possibly some loss there if we don't address this like we should. I'm not going to miss having to do the administrative stuff. I don't think you'll learn anything from that coding. Like, seriously, that I didn't go into medicine so that I could code for billing. Like, right? We say that all the time. So for a lot of those things, yes, please get those done first. But for some of these other things, I think we're going to need some time to make sure that we're still able to be that operator and to understand how we come up with a differential diagnosis, think back, on the biochemistry of this endocrinology problem or this genetic metabolism type problem. I was grateful for having to learn all these metabolic pathways because then I could think about why treatments worked, with certain patients. So I was grateful for that. We just need to figure out how our trainees don't lose that capability. Where I think there's a caution too is for patients. I do love the idea that AI is kind of that leveler because, for far too long, healthcare medicine has been paternalistic and it's, whatever the doctor says. And maybe there's some inquisitiveness, but there also maybe wasn't the time that the clinician took to explain things to patients. Well, with AI, with the internet, but now AI, people could ask questions of the AI tool. God help me, do not put your medical information into ChatGPT or Claude or Perplexity or any of those. But they could ask questions about their symptoms and kind of come up with a differential. And I usually caution people, I try and tell people that I know and patients, bring that information to your physician and say, you know what, help me out with this. So make it a shared responsibility to talk about it. And then it's your physician's responsibility to explain, I know Claude said that. However, here's, why it's not, because they may have more information, more context. They know you, maybe they don't know you. But so I think there's caution for patients as well. There's an eagerness to want to know, right? Because you could just go right on your computer and get that information right away, whereas it could take you a lot more time to see your physician. So I think we need to work that out too. So that's another area of caution.
Yeah, I agree with all of that. Touching on the patient piece, I think 10, 15 years ago, we used to kind of roll our eyes when our patients Googled their symptoms. And now I think we almost have to expect that they're going to their symptoms into ChatGPT or Claude or another AI tool. And they're going to have maybe not even a baseline knowledge, but they're going to have some curiosity and some questions about what they're finding, what they're hearing about, or they go on Reddit, which is not AI, but sort of internet rabbit hole.
I like the idea of patients doing that because we want patients to feel empowered to take charge of their health and their healthcare. I do caution that a lot of what we see on the internet, you mentioned Reddit, people need to know that a lot of this stuff is not right. I see this all the time. Well, this influencer said, there's this supplement and it worked for that person. I call it the N of one. I've written about this, the N of one. Like, great. It might have worked or it might just be whatever happened. It was the natural course of whatever the condition that they had. And so, what I'd like to see incorporated in patient visits is clinicians, physicians kind of getting ahead of it and saying, I know you're probably going to put this in your AI tool, let me caution you, and here's why. Here's how a better way that you could use it. And I think we should embrace that leveling because I like it. When I was in the ER and a patient came and they were informed, and in fact, those were the people that inspired me to write this book, because in pediatric emergency medicine, it was the special needs kids. I worked in level 1 trauma centers, children's hospitals, and at least a quarter of our patients were children with medical complexity and special healthcare needs. Their parents came with these white binders full of their information, made my job easier. They knew their kid, they knew what they needed. And I thought that that was really great. And in my book, I call them the white binder parents or the white binder patients. And being armed with that information, I think can only improve your outcomes. And it also can improve your finances as well. But I think it's going to be that accelerator of leveling that playing field. And I think clinicians, we should embrace that. I think it can be a good thing. There's good and bad to everything, but I think overall it'll be a good thing.
Yeah, I absolutely agree. It's empowering for the patients to take that level of interest in their own care and to seek out that information and to have that conversation. Going back to another use case for AI that I don't hear a lot about, and I don't know if it's just I'm not looking in the right place, but on the clinical decision support side, I'm thinking more about, so again, I worked in family medicine, primary care, a lot of chronic medical conditions, patients that would come in for their 6-month, 3-month, yearly checkups. They're seeing all kinds of specialists. They're on 20 different medications. And a lot of the physicians and clinicians that I work with as clients who struggle with their charting say that their biggest challenge is what they mostly call it as pre-charting. So they're prepping their charts, right, for the day. They're looking to see what specialist has the patient seen. Mm-hmm. Have they had their annual screenings? Have they had their vaccinations or immunizations? What was their last echocardiogram? Those type of details that are very disparate in the chart. They're hard to find. You could look through a 65-page hospital report looking for the ejection fraction on a patient. That's where I see a great use for AI is to go into search this medical record and identify what were the specialists the patient saw, what were summarized changes to treatment plan, what imaging has been done, and not to interpret the findings, but to even drop them in, all those things, like provide me a summary on what's going on with the patient since I saw them 3 months ago.
And there are tools that do that, but that's a complex issue. Okay. So if you're in one healthcare system, let's say you have a patient that gets all of their care at Kaiser or Mayo or Cleveland Clinic, all their care. They get their x-rays, their lab work, their subspecialists, everything. I wouldn't say it's simple, but it's a simpler issue. Then whatever that tool is just needs to extract the pertinent information and put it into a summary, a pre-visit summary. And that can already be done. That's already being done. And when it becomes complex is that if your primary care provider, or I should say clinician or physician, works in one place for one institution, but your subspecialty care is out in the community somewhere else, you get your radiology done, somewhere else and all of that. Gathering that information then becomes a little more complex, right? It's not in that one EHR. And just like a big health system, it would all be in the EHR. So you have to have tools that can extract that data from other places. That's typically done in this country through health information exchanges. It's not a simple thing because it's not like it automatically feeds into that patient's EHR. The clinician has to pull that information from a health information exchange. And it is, especially with complex patients, if you've got multiple chronic conditions, you're seeing in multiple places, you've had a ton of hospital visits, it becomes a complex feat. Now, you just reminded me, this is like PTSD. I had to go, when my mother was alive, and I had to go through her medical record. She had hospital visits and she had chronic care visits. And I was going through the EHR stuff, and it was like, seriously, 3,000 pages. I don't know. That wasn't an exaggeration. And most of it was repetitive. It was not useful. It was garbage. And so what you described, being able to just extract the important pieces without that repetition is hugely valuable, right? Right now, where most people have to do it is what I was describing, this white binder thing, families keeping that information either in electronic form or in a binder. But we're going to get there. There are tools already that are doing that. I think there's some ambient AI scribes that'll organize stuff like that and do pre-visit summaries. So that'll exist. I think, having that digital front door, pre-visit preparation, within that visit, doing the documentation and organizing the note to ordering, right? We're already seeing this autonomous ordering systems right now, and they're being tested. But, doing those orders, having that clinical decision support, all as layers and integrated into that EHR, and then the post-visit follow-ups as well, I think that will help smooth out a lot of the friction points in healthcare. I think, though, it's not going to solve all problems. Healthcare is still complex. We still have a system that's not going to be fixed unless there are policy fixes, policy and regulatory fixes. But I think AI is going to help smooth out those rough spots. But yeah, you hit it, where we really need that kind of help with AI tools.
Yeah, thanks for clarifying that. And I'm glad to know that there are some tools out there, because I think that's a big administrative burden for our clinicians too.
Absolutely.
Well, tell us about the book.
Okay. The book is called The Prepared Patient, Your Guide to Surviving the Healthcare System. And it takes somebody through healthcare coverage. It's probably the biggest chapter. It was really shocking to me that people that are educated, intelligent, you would think would know about health plans and what a deductible was, what a coinsurance was, and all that. People don't. And in fact, there's a figure that came out of the Department of Health and Human Services that only 12% of people in this country are fully health literate. And so I always tell this story. My daughter, smart girl, young lady, I should say, graduated law school, and she was looking at her insurance card. And this is as I'm writing the book. And she's like, well, which is this number? And how do I know what my deductible? She was trying to figure it out and she couldn't. I'm like, oh my God, I need to have a picture in the book with identifying what that is. Same thing for the information that you get from insurance companies. How do you read that? And how do you choose a healthcare plan? And what are the different plans out there? And how do you plan for that? It takes people through their life cycle, starting from birth, because we will all be patients one day.
Yeah.
All of us. So from birth all the way to the end of life, what can you expect? How do you find a primary care provider? What are the terms that are used? How are they educated? What's the difference between a nurse practitioner and a physician? Talks about that, talks about what to expect at different stages of your child's journey with their pediatrician to young adults, all the way to older people. And then it has in the last chapters, know your rights. And I really encourage people to inquire about surprise bills, because you have rights when it comes to that, right? There are laws around that. If you don't understand your explanation of benefits, one, that's not a bill. But if you don't understand it, then you need to call. And I know this is time consuming and so on, but you shouldn't be on the hook for paying for something that you shouldn't. How do you evaluate a pre-authorization, right? How do you appeal that? And you should appeal it if, it's supposed to be covered, right? How do you find less expensive medications, right? But there's starting to be companies like Cost Plus Drugs and Good RX and Trump RX and all these things for less expensive medications. But there are other places as well. So I try and articulate those things as well. So it's pretty comprehensive. I couldn't stop writing when it got to that. There's so much friction. There's so much that people have to deal with the healthcare system.
That sounds like something everybody needs to read. And I'm looking forward to reading it myself when it comes out. Like you said, we're all going to be patients, and our family members are going to be patients. This affects everybody. And I think we've kind of had this denial. Well, I don't really understand it. And so it's too complicated. And we have to shed all that, right? We have to remove that notion that it is complex, but we also need to understand it so we can advocate for ourselves. And I've had, from the physician standpoint, I've had patients come to me and show me, well, I got this letter from the insurance company. Can you help me understand what it means? And one of two things, either I'm surprised about something that's happened in their care,
Yeah.
Or I might not even have the knowledge of the terms that are in that letter
Yeah.
to begin with. So then I'm embarrassed because I'm like, I'm sorry, I don't know what this means, but I wasn't trained in this. I wasn't taught this when I was in school.
There's very little business of medicine. Not that I necessarily think it needs to be taught, but you need to pick it up at somewhere along the way, right? So you're
Yeah.
exactly right. It's so complex, and it not only has health implications, but has financial implications.
Right.
I mean, when 2/3 of GoFundMe are related to healthcare healthcare costs, and people go bankrupt. I think it's 2/3 of bankruptcies are due to medical issues, and it's about 1/3 or 40% of GoFundMe's are people raising money because they have unexpected bills, and it can happen to anybody. You can get an illness without. You could say, okay, I'm 32 years old, I'm really healthy, but you don't know if you're diagnosed with something or you get hit by a car. That's really, really high cost, very expensive things that happen, and the prices are so high. So at least if you're prepared and you understand the system, you can maybe prevent at least some of that.
Yeah. And the more we advocate for ourselves, the more we can create policies and regulations that help protect us, like the legislation around surprise billing. Yeah, definitely excited to read the book and shout it from the rooftops when it comes out. Where can we find it when it is available?
Well, it's coming out on August 11th is when it'll be officially released. It's available for pre-order now, and you can get it from Barnes & Noble and also the Johns Hopkins University Press. Any of those places. Most people I know say, I'll just go on Amazon, and you can get it there.
Awesome. Well, it's so wonderful to talk to you. This is an incredible conversation. Thank you for being on.
Thank you. And it's so great to talk to someone who knows all of these things that you think is only a secret amongst those of us. So thank you. This was a delightful conversation.
Yeah, great to have you.
Thank you.
If what you heard today resonates and you're ready to find out what's actually driving turnover in your organization, I'd invite you to book a retention strategy call with me. Go to drlaurasutton.com/strategy call. We'll look at what's driving clinicians out the door in your organization and what it's going to take to fix it. I'll see you next time. This podcast is for educational and informational purposes only. It is not medical advice, and it should not replace care from a qualified healthcare provider. Always seek the guidance of your physician or other qualified professional for any medical questions or decisions.